Hi, this is Kimberly Langer. I'm a nurse practitioner student at Winona State University. My current practice is acute care nurse practitioner and blood and marrow transplant at Mayo Clinic Rochester. I'm currently working on my doctoral degree and have finished my clinical and core courses for family nurse practitioner and awaiting to sit a board exam. My colleague who's working with me on this doctoral project is David Steele, who many of you know, who is also a family nurse practitioner who completed his acute care nurse practitioner clinical and core courses and is also working on his doctoral degree as well, period. And together we're working on a project called Bronchitis, an evidence-based practice DNP project. And what this project entails is looking at the use of antibiotics for the treatment of acute bronchitis. And what David and I have done is done some literature review as well as a survey done by your colleagues at United ER there to see who uses evidence-based practice, who prescribes antibiotics for the diagnosis code of acute bronchitis and such. So this PowerPoint here is just a basic overview of our project, our education that we're providing with the providers, and what we hope the outcome will be. So what is uncomplicated acute bronchitis? And as many of you know, this is an infection of the conduction airways of the lungs, usually 95% viral in nature, thus usually not warranting antimicrobial treatments. Specific viruses that we typically see include respiratory syntactical virus or RSV, rhinovirus, influenza, and or parainfluenza. Now there are certain times when we can see a bacterial infection, and this is only about 5% of the time and is more so associated with what we term complicated bronchitis. Complicated bronchitis is defined as a patient who is age greater than 65 years of age, can have restrictive lung disease, is immunocompromised in terms of being on immunosuppression, steroids and such, or the bacterial diagnosis including bacterial pathogens including mycoplasma, chlamydia, pneumonia, and bordetella pertussis. In terms of prevalence, looking back at the research in 2008, over 5 million people sought care for upper respiratory infections, and this constituted 5% of all total ED visits, and this was a study done by Muratora et al. In 2008. In terms of when antibiotics were prescribed, in the primary care setting, 75% of patients got antibiotics, and this was a study done by Lee et al. In 2014. And in emergency medicine visits, 42.2% of patients from a study by Stones et al. In 2000, and 75% of patients in a study by Tackett and Atkins in 2012 received antibiotics. So as you can see, antibiotics are used quite frequently actually to treat an acute viral illness, thus leading to the issues of antimicrobial resistance. So up at the Peter J. King Emergency Care Center, which is where David and I are working on our project, we've actually done a retrospective chart review, and our study period was from October 1st, 2014 to February 28th, 2015. The breakdown of providers were physicians were 26.6% and advanced practice providers were 73.3% of the providers seeing the patients of the charts reviewed. Of the charts reviewed, 49.4% of the patients were diagnosed with uncomplicated bronchitis, yet received antibiotics. And our study group was 90, so there were 90 charts that were reviewed that had the diagnosis code of uncomplicated bronchitis, and roughly half of them received antibiotics. Of that, physicians were 14.61% guilty of writing the antimicrobial prescriptions, and advanced practice providers were 34.8%. And there was no statistical difference between the two categories with a p-value of 0.6384. So looking back now, we talked about a retrospective chart review and a little bit about uncomplicated bronchitis, which is a very formal topic. So what does the literature say? So with our project, David and I did a literature review looking at different studies and clinical guidelines about how to treat acute bronchitis. And so what the literature says in the different studies we reviewed, the first study by Rodnick et al. Was actually a study that looked at 5 randomized controlled studies that had an intervention of using antibiotics for the treatment of bronchitis. And the different antibiotics used included doxycycline, erythromycin, and Bactrim. And of the antibiotics used, not one study showed an overall improved outcome of the patients. Thus, all the studies showed that the patients were still just as sick, just as long. There was not an improvement in cough or improvement of symptoms and such. A secondary study that was reviewed was the Cochrane review. And now this is a review of 17 different studies for which patients got the intervention was patients getting antibiotics with the diagnosis code of bronchitis as well. And the study written by Fahey et al. 2014, which was the Cochrane review, there was absolutely no benefit of getting the antibiotics. So again, symptoms didn't improve any faster, patients didn't improve any faster when you compared the control group with the intervention group. A couple of secondary studies, the first one by Lort et al. From 2013 was a multi-center single-blinded controlled study which actually had 3 different groups. There was a control group, an anti-inflammatory group, and an antimicrobial group. The anti-inflammatory group where patients received ibuprofen as a terms of supportive care, and the antibiotic group was doxycycline. And really within this study, again, there was no statistical difference found between the standard, the anti-inflammatory, or the antimicrobial groups. And a final study by Linder and Sim reviewed 9 different studies regarding smokers and acute bronchitis, and 7 of the studies showed absolutely no benefit by giving smokers antibiotics with the treatment of acute bronchitis. One study did show reduced cough length, but this, I guess, would be more symptomology, so you'd have to figure out how we would actually term reduced cough length, because patients always have a lingering cough, maybe just not as aggressive or productive, if you will. So as we can see, the literature does show that there's not a whole lot of support to use antibiotics for this diagnosis. And then clinical care guidelines. So David and I found 5 clinical care guidelines regarding the treatment of acute bronchitis. The side note of these is that none of the clinical guidelines were from emergency medicine literature. They were all from primary care. But with that, all of them did aim at the treatment of acute bronchitis. So whether it was obtaining a chest x-ray, using antibiotics, or more so supportive care, that's what we were looking for. And all of the 5 guidelines that were reviewed, we did do the AGREE tool, which is a tool used to score guidelines. And a couple of the guidelines actually scored kind of poorly, just given the way they were written and their applicability. But 3 of the guidelines actually scored very highly. And all of them did support using supportive care measures, including nebulizers, antipyretics, and Tessalon pearls and such of those nature to help treat acute bronchitis versus actually using antibiotics. And again, here as our last statement is, with all the clinical care guidelines, all state no antibiotics for uncomplicated bronchitis.
Thanks, Kim. So this is the algorithm that Kim and I came up with to guide your treatment approach to acute uncomplicated bronchitis. So we researched the literature and looked at our 5 clinical guidelines and then made our own that was more specific to emergency medicine. There were no emergency medicine algorithms available to use. So the first thing we need to define is acute uncomplicated bronchitis. So the patients excluded, as you see in the upper right box, are anybody over the age of 65 years, restricted lung disease, either COPD, bronchiectasis, emphysema, or anybody that's immunocompromised. Those would be considered complicated bronchitis, and antibiotics may or may not apply to those patients. So acute uncomplicated bronchitis really is also coined acute cough illness. And as you can see here, the diagnosis criteria is cough is dominant, plus or minus phlegm, and there's no literature that shows that green sputum or yellow sputum, those patients require antibiotics. And I think when I went through my initial program, they were still teaching that, but that is no longer true. The amount of sputum in the uncomplicated patients, it doesn't matter. It's still a viral illness. And then you can have bronchi or mild wheezing present. So then you move down to the next decision box, and you have to decide if they have abnormal vital signs, which would be heart rate over 100, a respiratory rate greater than 24, a temp greater than 100.4, and then if there's any focal lung findings like crackles in the right midlobe, etc. If those are present, then you want to consider getting a chest x-ray because those patients would be more at risk for pneumonia or something more serious going on. So if there's an infiltrate present, you'd want to consider antibiotics. If there's no infiltrate present, you want to consider another diagnosis. And if there is no other diagnosis, then treat as uncomplicated bronchitis. And really in this decision box, it's if they have an infiltrate, treat it as pneumonia. If they don't, more than likely you're going to call it bronchitis. If they don't have abnormal vital signs, the recommended treatment, according to the literature for uncomplicated bronchitis, antibiotics are not indicated, and we've talked about that already. So basically it's supportive treatment, beta agonist bronchodilators if there's wheezing. Literature says that antitussives such as benzoate, which is the Tussilon pearls, dextromethorphan, codeine, or hydrocodone cough-based medications will probably be helpful. I think those are category B recommendations. And then supportive care, rest, fluids, stop smoking, which typically many of these patients are smoking. And the literature does not support the use of expectorants or mucolytics like guaifenesin. So why do we worry about antibiotics in bronchitis? Well, the answer is simple. Because of antibiotic resistance. Lee et al. In his article state that the use of antibiotics is the single most driver in antibiotic resistance. VRE, MRSA, and flagell-resistant C. diff have all resulted due to overuse of antibiotics. Per Frieden, pneumococcal pneumonia resistance to the macrolides has increased to 36%. And in reviewing what's important or what is the threshold, the CDC states anything over 30% is a great concern. And in the Twin Cities, we have a roughly between 30 and 40% antibiotic resistance to pneumococcal pneumonia, resistance to macrolides. And so macrolides are no longer recommended as a first-line treatment for pneumonia. And this is concerning. Over 2 million people a year will develop serious resistant infections, and 23,000 of those patients will die from those infections. So that in and of itself is concerning. And then also there's an added cost. Cost to the economy for treatment of these resistant infections is estimated at $20 billion. In 1995, the CDC started a Get Smart campaign. These actually were, each state was given federal funding, and each state developed an antibiotic resistance type of program. And this has been an ongoing campaign, but now it's federalized, and some of the literature, the posters that you'll see in a few slides, originated from the Get Smart campaign. So if you remember back a few months ago, I put a survey on SurveyMonkey for the United providers to fill out, and I want to go through those results now. So the provider type, the MD group were a total of 40% of the responders, and the NPPA group were 60%. And our response rate was roughly 67%, which is great for a survey. I thank you all for filling this out. We gleaned some important information. The first question I want to look at is, do you practice evidence-based medicine? This was a yes or no question when it should have probably been, we would have obtained better information if we used a Likert scale, because, you know, in some cases there isn't evidence-based, there isn't evidence to support what we're doing. In other cases, it's quite clear. but since I'm a black and white thinker, it was a yes or no. And 93% of you say that you do use evidence-based practice. 7% say you don't. And then the next question was, do you prescribe antibiotics for uncomplicated bronchitis? Yes was 0%, no was 100%. And as Kim mentioned, roughly 49% of people at United prescribe antibiotics for uncomplicated bronchitis. So there is a mismatch here, and hopefully through the education and the intervention we can make this statement true, and 0% will be prescribed antibiotics. What makes bronchitis complicated? Age is 65, greater than 65, 39%. Diabetes, 29%. Asthma, 42%. Restricted pulmonary disease, 82%. Smoking, 23%. Immunosuppression, 77%. Heart disease, 6%. And others, 3%. So we got most of these here. So remember, complicated bronchitis is anybody over the age of 65, restricted pulmonary disease, and immunosuppression. So history of asthma, history of smoking does not matter because the literature just does not support the use of antibiotics. And the last question was, are you aware of any evidence-based guidelines for the treatment of bronchitis? And 66% of you said yes, and 34% said no. Hopefully after the intervention today, again, this would be 100% that you now are aware of evidence-based guidelines. Then I asked a question about what's your motivation for prescribing antibiotics for uncomplicated bronchitis, and 13% said increases patient satisfaction. And according to the literature review, this is probably the #1 reason or #2 reason why people prescribe antibiotics is there's that pressure from parents or from patients, and they usually say, well, my provider gave me antibiotics the last time I had bronchitis. I want them again. It's the only thing that makes me better. Does antibiotic resistance concern you? And 100% said yes, which I'm glad to hear. And then, are you willing to change practice through some type of intervention if you were not practicing evidence-based medicine? 100% of you said yes. This is excellent news because now we can change practice and stop prescribing antibiotics for acute uncomplicated bronchitis. So what's the current practice at the Peter J. King Emergency Care Center? We looked at the same study period, which is October 1st until February 28th. However, this was last year. There were 90 patients in the study that we determined were acute uncomplicated bronchitis. We searched both bronchitis ICD-9 code and bronchitis NOS ICD-9 code. The mean age was 37.82 with a range from 18 to 65. Again, remember, anybody over 65 is considered complicated. This was surprising to me. 70% were female and only 30% were male. I would have assumed this was more 50-50. I'm not sure what to make of this. And the provider mix in the study was MDs were 26.6%, and the APPs total were 73.3% that made these diagnoses. So we looked at ESI triage categories, and I think this is self-explanatory. 41% of patients were labeled as a Category 3, and Category 4 were 54.4% of patients, 0 Category 5s. So this is why we are kind of focusing on rooms 6, 7, and 8, our rapid treatment rooms, to hang the posters in, because most of these patients are being seen in the rapid treatment area. We were interested in the race of the patient. Asian were 3.3% of the population. Black or African American was 51.1% of the population. Declined race patients were 2.2%, and white or Caucasian were 43.3%. We did look at p-values to see if there's a statistical difference between patients who got antibiotics and their race, and there was not. So we are equal opportunity destroyers as far as giving antibiotics to patients with uncomplicated bronchitis. It doesn't matter what race they are. As far as the antibiotics prescribed by category, again, 49.4% of patients in uncomplicated acute bronchitis were given antibiotics. The provider group, 14.61% of the provider MD-DO group gave antibiotics, and the APPs were 34.8%. And if you remember back to a previous slide, total MD-DO group was roughly 28%, and the APP group was in the 70%. So roughly half of the providers in each group gave antibiotics. And again, we looked at if there was statistical significance or difference among the provider categories between the APPs and the MDs. Again, there was no difference with a P of 0.6384. Now this is the money slide for the presentation. First off, were radiology tests completed, either chest x-ray or CT. 90% of patients had imaging done. And was there a difference among those who had imaging and prescribed an antibiotic? And again, no, there wasn't, with a P of 0.1572. So we were kind of thinking this through, and I thought, well, geez, if patients are getting an antibiotic or getting an x-ray and it's a negative chest x-ray, because if it's positive you should be diagnosing them with pneumonia or a different diagnosis. If it's negative, then for sure you would be reassured that they don't have an infectious process, and I would think we would be less likely to prescribe antibiotics, but obviously this was not the case. And again, just a reminder, if they have no abnormal lung sounds and no abnormal vital signs, you really don't need to do an x-ray on these patients. And lastly, on this slide, of the patients who were given antibiotics, what antibiotic categories were prescribed. Cephalosporins were 2.2%, fluoroquinolones are 11.1%, macrolides were 77.7%, and tetracycline, typically it was doxycycline, with 8.8%. So you can see here 77.7% of patients were given azithromycin for a viral illness, and now we have between 30 and 40% macrolide resistance to strep pneumoniae pneumonia. So we need to really think about this and change our practice. So using literature to guide us, Kim and I decided on a few interventions, and we abandoned a few interventions to look at how we can decrease antibiotics. And the big one is the educational intervention. This was given live at the United provider meeting or emergency department meeting, which happened last week. I appreciate everybody attending. Those that haven't, I'm glad you're listening to this now. We will start doing email reminders bi-monthly, similar to what Dr. Fritzler already does with stroke care and sepsis, just regarding some pearls of care, maybe new literature that comes out, maybe talk about resistance, something to keep this in the forefront of your mind. We're placing posters in rooms 6, 7, and 8, and I will show those in the next few slides. I'm probably going to come up with a smart phrase or .mdm, which is medical decision making, specific to bronchitis, so you could pull that into your note. I'm working with Dr. Fritzler on that. And the study period, again, remember, starts from October 1st of this year and goes until February 28th of 2016. This is the first poster that we'll place. Again, it's from the Get Smart campaign. Hopefully patients will read this while they're waiting, and we can also, as providers, point these pictures out, talking about antibiotics don't work for viruses like the colds and the flu, and using them for viruses will not make you feel better or get back to work faster. The second poster that we will be hanging are conditions which are viral versus bacterial. And hopefully, again, you can point this out while you're in the room discharging the patient, or hopefully they'll be reading these. But you can see for bronchitis or chest cold, it's considered a virus and we're not supposed to use antibiotics. Interestingly enough, fluid in the middle ear or otitis media with diffusion is no longer is it recommended that you use antibiotics because it's usually a viral condition. So this would be another interesting project for somebody that so desires to take it on. Our abandoned ideas. One was due to not enough literature to support it. The second was due to time length to get it implemented. But basically, the first one I thought would be interesting was just another maybe lab test to support or not support giving antibiotics. There has been some literature regarding procalcitonin and when to use it for bacterial infections or what would constitute a bacterial infection. There was only one study that I found that addressed this topic at all in bronchitis, and it was kind of it was not the aim of the study or the goal of the study, but it was their impression, and their impression was anybody with a procalcitonin of less than 0.25 would not need antibiotics, and anybody with a procalcitonin higher than that should get antibiotics. But again, this was not the aim of the research study, and this was their hypothesis at the end as an incidental finding. So since there wasn't enough literature to support it, we abandoned that idea. And again, if somebody wants to do some research, this might be a good topic to look at. The last thing we were talking about doing was to put a flag in the electronic medical record, or EPIC. And basically, when you diagnose somebody with bronchitis or the ICD-9 or 10 code, this flag would pop up saying this is roughly a viral illness, and you should not be using antibiotics. However, this has to be approved through the Emergency Medicine Committee in all of Alina, which there's approximately 13 EDs, I believe, and 1 urgent care. And in discussion with Dr. Fritzler, it roughly takes a year to get things moved and approved through this committee, and we just didn't have the time, so that idea was abandoned. I know there's not an opportunity for people to answer live or ask live questions. However, if you have a question, send me an email at david.steele@eccemergency.com. I'd be happy to answer them. I'll get Kim's input. I do want to talk about a conversation that we had in our live meeting, and it related to coding of bronchitis. So the discussion was had regarding, I don't even code bronchitis patients as bronchitis. I usually call them a cold, or call them a cough, or call it URI with cough. So I'm asking you, at least for this study, to code patients that belong in the bronchitis category as bronchitis. And again, the diagnostic criteria is predominant cough illness, plus or minus sputum, and plus or minus wheezing, with no other diagnosis or no risk factors of complicated bronchitis. So those should be coded as bronchitis. What I don't want to happen is that practice doesn't change, and then people, since we're not looking at other categories of diagnosis, start using a category of cough or diagnosis category of URI with cough, and then continue to prescribe antibiotics, because that would defeat the purpose, and more importantly, it's going to eventually, and it already has, impact patient care. I want to take a minute to thank you for your time. This has been a interesting project. I hope we can make a difference. And if, again, any questions, please drop me an email. And thanks for listening. The next two slides are our references.